the goal is to get some kind of a little bit of variety of experience with different types of overdoses and see what you would do in different scenarios. So I'll give you for each case a few minutes to discuss with your groups, and then we'll discuss. And I will mostly call on you by group number to help make sure that everybody is participating. So by the pre-class material and through our discussions today, you should be able to describe the general assessment and management of patients with acute overdoses. You should be able to evaluate the options for managing overdose with selected toxins, and you should be able to develop a pharmaceutical plan for acute overdose patients. So we'll go right into our first case. This is a pretty simpler case, but one that you could encounter something similar to this pretty frequently. So you're working at a community pharmacy, and a 31-year-old female calls you in a hysterical cry because her 6-year-old accidentally brushed his teeth with icy hot. So talk to your group just for a couple minutes, and just in general, what is your response? You don't need a detailed plan here, but in general, what's your response going to be when you get this call as the community pharmacist? So discuss with your group for a couple minutes here.
1-800-222. Yeah. 1-800-222. Why was that not on the first?
Yeah, that should have been a quiz question. It's actually kind of.
I think that's kind of funny. Not gonna lie.
Kind of cute. Yeah, brushing with ice hot.
I mean, is it really going to hurt you? It's just going to burn for a while, right?
Yeah, right?
Yeah. Imagine the pain when it
Mouthwash.
when you realize what was
Or switch your mouth out
Yeah,
with some
switch
water.
up some water.
Oh, sorry. Are you trying to
I would be crazy to my mother. I mean, it's a 6-year-old.
How am I saying it? Do it on purpose. That's okay. You know what? I probably deserve that.
Oh, my 6-year-old brushing their teeth on their own floss.
Well, they did it wrong.
It takes a lot for children to brush their teeth without being told to brush their teeth. Or like, don't they have like fun ghetto sounds with their teeth?
What do you want to do? I want to tell her to stop crying.
Please stop.
Like, I don't got time for this.
Ask her what other drugs he's taking. Any drug allergies?
Spanish today. Look at how many tabs I have in my phone. My phone is trying to say tab and something.
All right, so you got this frantic call from a mom. You don't have much time to prepare to answer this question, so what are you going to say? So group 10. Where's group 10? All right, what would y'all do? What would you tell her?
Sorry, y'all. I was looking at your
I think we're going to call it poison control first and foremost.
Does anyone agree, disagree? Awesome, yes, call poison control. What's the phone number?
1-800-222.
Yay, okay. So whenever there's an acute intoxication, especially if you're in the community, oftentimes when you're in the hospital setting as well, you want to call poison control. So this is definitely what you'll do in the community. Even in the hospital setting, there's some overdoses where we will still call, even though we can do all the supportive care, we have access to antidotes if they're available. If we call the poison control, they will give specific regimens for how to treat that overdose. So it's not uncommon in the hospital or even in the ICU setting to still call poison control and get their recommendations, particularly for intoxications that are less commonly seen. All right, so case 2, this one is now a little more complex. So we have a 76-year-old male with a past medical history of dementia. He's brought in by a caregiver because he had urinary and bowel incontinence 4 times today, and he was confused. She soon realized that he took a whole week's worth of his medication by mistake. So the physician ordered an EKG, a KUV, a urine depth screen, and a digoxin level every 6 hours. So vital signs are listed here as well as the lab values and his home medication list. So we're going to be a two-part question. Part one is what kind of symptoms and signs are we going to see based on this intoxication? The second part will be what do we want to do about it. So first, start thinking about just this first question as well. At first, what signs and symptoms would you expect to see from this intoxication? We'll go over it in a couple minutes.
No wonder you keep having incontinence. You took all of your first night at twice.
Oh gosh. Oh, sounds miserable. Alright, visual disturbances.
The one that's like, not shooting in red. It's all the red goods.
Absorbs everything, right?
No.
Yeah, trying to remember that. It's like
Something about my gnome dog.
my hyper dog is the dumbest dog. Yeah.
How do I make this smaller to where this takes up most of the screen?
I'm not entirely sure how to work it. What is it? What do you want?
I want this to go over.
It's not pulling?
So this gets bigger.
Well,
I think you just have to collapse the whole thing.
How?
Go to, where is it? Or it would be colon because it's anti-cholinesterase.
Wait, is there an option to do that? Like if there's two things down here, like at the very bottom, you can do like the grid or the like normal thing, but I don't know.
There we go.
Does that work?
That works.
All right, let's start talking about what kind of signs and symptoms you would see. So I think it can be helpful when you have a situation like this where there's a possibility that a patient has ingested multiple different medications. I think it can be helpful to think about what types of signs and symptoms you might expect from each of those overdoses, and then look at the patient as a whole to see what's actually going on and if it matches up with what you expect based on the drugs that they ingested. Another important thing to keep in mind is that it's very essential to get a detailed history about the patient to know what types of exposures they may have had, but it doesn't mean that the information you got is necessarily accurate. So the caregiver, to the best of her knowledge may have thought that the patient took a whole week's worth of all of these medications, but it may be that in fact he took a week's worth of just one of them, or took a whole month's worth of one but not any of the others. And so we want to absolutely get that history because it can be very helpful, but also keep in mind that it's not always accurate. So let's think about what symptoms and signs we might see for each of these individual medications. So group 12. Where's group 12? What would you expect from furosemide overdose? Yeah, so I don't know if everybody else can hear you on other campuses, but he said decreased blood pressure. Anything else?
Loss of fluids.
Yeah, so they may become dehydrated, could develop an acute kidney injury. So all of those are things you could do with furosemide. And I put just a couple things on my list, but we said decreased blood pressure for sure, and there could also be others. You could do electrolyte abnormalities, for example. All right, group 16. Are you in Augusta?
Yes.
What would you expect to see with ribostigmine overdose?
We said minuses, increased bowel sounds and sweating, and then the dumbbells acronym.
Sure. Good. Anything else? All right. What's part of the dumbbells?
Diarrhea, urination, meiosis, bradycardia, bronchospasm, bronchorrhea, emesis, lacrimation, and salivation.
Good. So we can see any of those cholinergic type symptoms. All right. What about fluoxetine? How about group 19? Where are you, 19?
We're in Augusta as well.
Oh, okay.
We said serotonin syndrome and neuroleptic malignant syndrome. So for serotonin syndrome, myoclonus, hyperreflexia, diaphoresis, incoordination, tremor, diarrhea, agitation, AMS, and hyperthermia. And then for neuroleptic malignant syndrome, we said fever, elevated creatinine, kinase, vitals, instability, encephalopathy, and rigidity.
So it's a serotonergic agent, so we could see serotonin syndrome. You could also see neuroleptic malignant syndrome. Serotonin syndrome is probably a little more likely, but you could see either. You could also see some hyponatremia. Is a kind of somewhat unique one to think about here. All right, so let's go to group 24. You're in Savannah, I think, right? What would you see with an aspirin intoxication?
We said hyperventilation, tinnitus, listlessness, coma, seizures, hallucination, cerebral edema, hypotension.
All right, so you have your whole chart, right? And it depends a little bit on how severe the intoxication is. So this is a case where if we were concerned for aspirin intoxication, we could get a serum level and see how high it is, and that might correlate with different degrees of symptoms. All right, group 2. What would you see with digoxin toxicity? Where's group 2? Right here.
The main ones would be visual disturbances and arrhythmias, but you could also have lethargy, confusion, anorexia, nausea, vomiting, diarrhea, and abdominal pain.
Good. So the visual disturbances and arrhythmias are very characteristic of digoxin toxicity. But you can have a lot of other symptoms as well, and they also depend on the degree of toxicity, so how high your digoxin level is. And that's another one where we can check your serum level. All right, we've got 2 left. So nortriptyline, group 7. What class of drug is this and what symptoms might you see? Group 7.
Fatal arrhythmias and seizures, and then what did you say? Anticholinergic effects.
Okay. What class is nortriptyline in?
It's a TCA.
Yeah, tricyclic antidepressant. So that's absolutely correct. All right, and last one, flip the side. Let's do an Albany group. How about group 22?
Hypoglycemia, dizziness, and blurred vision.
Perfect. So hypoglycemia and then the signs and symptoms that go along with it. So when we think about a patient and look at the patient, some of their presenting symptoms, some of the labs, so altered mental status, confusion could fit in with some of the several different home medications. We have some electrolyte abnormalities that might come to play with the digoxin particularly. And we do see some hypoglycemia as well, right? His blood sugar is 35, so that's likely from our glucoside intoxication. So we want to kind of look at the patient's ingestions, possible ingestions, look at what's going on with them clinically, and then decide from there what we're going to do in terms of treatment. So now we have some orders that we, the pharmacist, are going to have in our queue to verify that the treating team has put in. So we want to think about these orders and determine, are these orders appropriate? Are there any interventions you would make? Would you recommend any changes in terms of how we're treating the patient? So let's talk for maybe, this is a little bit more complicated, maybe 7 or 8 minutes with your group and figure out kind of a comprehensive plan for this patient. How would you treat them and what changes would you make to the orders?
Should he get the MDAC since it's digoxin?
Her point is so not helpful because she just kind of split it all up. There's like 10 things happening at once.
Yeah, something about potassium.
Huh? But we don't like.
Do something about potassium.
7.4 is like a lot. We need to fix that, I feel like.
How do they? So they're giving them bicarb. Would that make it?
Well, you give IV calcium.
Which is what they're doing. They're giving calcium.
I don't know if it's supposed to be calcium gluconate or not.
You need dial.
Just hook him up to a dialysis
They might not be already. That's $150 delivery fee.
What is calcium supposed to be?
Huh?
What's calcium supposed to be? What
Like-
level?
8.5 to 10.5.
Heck if I knew. I feel like I don't really talk about calcium.
You give calcium with everything though. Like to fix the heart. Do they technically have hypomagnesium? Like, do they technically have hypomagnesium? Because it's at 1.4.
It needs to be up. It's greater than 2 and greater than 4 for mag and potassium.
Yeah, I was just like saying like for like treatment levels. Well, in our electrolyte thing, you treat it if it's below 1.4. So I didn't know.
I'm just going off of what Dr. said. I would use the mag level. And he's already, like, his heart, you're already like showing signs of cardiac effects because he's in BTAC.
With oral supplements?
How much does he weigh? Oh, 85 kilograms. This is good. I'm putting it in green. Good. Oh, that's very good.
I think the charcoal is supposed to be the multi-dose one though, so it's a lower dose. Is this the Johnson? And there's enterohepatic circulation.
Okay, wait. So 25 to 50 grams.
That's what I would think.
Just
I don't, guys, I was like so burnt out by the news thing. That was the very last question. She said one word answer. She did not want
Kidneys. All the
just one thing.
Just one
Just
thing.
put one of them, because only one of them does it. And you know the other one just shuts down. Speaking of one kidney, I do have a friend from undergraduate. See, that's why we can't put kidney different. She said you did it in the morning.
I'm pretty close with mom.
where does she talk about
She has one kidney and her brother has a horseshoe kidney, so I don't know what's
What is a
wrong.
horseshoe?
Meaning that he has technically one, but his two kidneys, but they're connected, so it creates one.
Like kidney tissue or?
Kidney tissue.
So he has a above average? He has a uni kidney.
Well, she only has one, like she.
I don't think they're supposed to use the sorbitol either, right? Because he's hypotensive.
Like she's straight up with one kidney.
Oh, that's what it says on the slide.
So don't use the
He took her kidney.
Is that
He used
insured?
other two kidneys together to form the. Now, does her one kidney work just as strong?
Where does it say that?
On slide
Or does she have below average?
She has.
13.
It's just been trained from birth to work.
Yeah.
If you actually look at her now, it's huge. It's like super big. It's super swole. One swole kidney.
So we wouldn't use Golightly either.
I guess not.
I was a boy.
Well,
No, that falls
Not
under a different
technically.
category.
yeah, it's just. But it says it can only be used within 6 hours. So when did he come?
She didn't say when.
I'll put it in yellow.
We could just put depending on like
Yeah.
the time we could use the.
could make on this case. So let's hear from a few different groups. You can all give us parts of your plans, and we'll see if, what we've all come up with together. So let's start with group 13. Where are you? In the back. All right. So give us at least one or two recommendations that you would make, and why.
So we thought that the activated charcoal dose was too low. It should be in grams, 1 gram per kilogram, so it should be 85 grams.
Okay.
And the same with the sorbitol, the dose is too low.
All right. So does anyone agree or disagree with changing the activated charcoal and the sorbitol doses?
We disagree.
I see a couple head nods, maybe. Group 1, what do you think? Is group 1 down here? Click on. What do you think about the activated charcoal and the sorbitol doses?
We think they're both okay.
They're okay as is?
Yes.
Okay, so we have one or two groups that say let's increase them. One group that says they're okay as is. What about group 4? Where are you?
It's supposed to be MDAC because
What do you guys think?
a list of drugs is right there that we use.
On the slide, it says when activated charcoal is given with sorbitol, 1 gram per kilogram once, max dose of 50 grams. So I guess 50 grams is max.
For the sorbitol or for the activated charcoal?
Wait, no, that's not.
That's a good question, right? So the 50 gram maximum applies to the sorbitol. So we definitely wouldn't go above 50 grams if we were giving sorbitol.
Just give.
Are there any other ways that we could dose activated charcoal?
I have a question. Are the units on that wrong? Did you mean to put 50 milligrams, or are we supposed to interpret that as a mistake?
No, so this is the order that the prescriber enters, so you have to correct that. So I agree that milligrams needs to be corrected. It should be in grams. Make that part clear, yes. But 50 is the maximum for the sorbitol. So are there any other ways that we could dose the activated charcoal?
We were thinking to change it to the multi-dose activated charcoal because digoxin was one of the drugs that you had listed to use for that.
Okay, so now we have it thought that maybe we should change it to the multi-dose activated charcoal. And how would you dose that?
We said 25 to 50 grams every 4 to 6 hours.
Yeah, so 25 to 50 grams, and we're going to repeat that. It's not just a one-time dose. So the reason that we do that for some drugs, such as digoxin, is because of enterohepatic recirculation. So if drugs have enterohepatic recirculation, then just giving a one-time dose isn't going to clear the drug completely, and we'll need the repeated doses. So since we do have digoxin involved here, I would probably do the multi-dose activated charcoal. Other questions about that?
Does the time window of 2 hours from ingestion apply to the utility, the MDAC as well, or no?
It does apply. So in this case, we don't really know exactly when the ingestion was, so it would be important to get a little bit more information about that. I see sometimes that 2 hour window being pushed out a little bit more with the multi-dose, but the earlier it's administered, the better. So if this was happened, the day prior, we would not give the multi-dose activated charcoal. We wouldn't give any charcoal. But if we were going to give charcoal, I would do the multi-dose activated charcoal, and we don't typically use the sorbitol with it when we're doing the multi-dose. All right. So let's see any other recommendations we can make. How about group 20? Are you in Augusta?
We said that the sodium bicarb should be switched to an infusion instead of just 1 ampule times 1 for the aspirin and the TCA overdose, and no sorbitol since he's hypertensive.
Exactly. So I would agree with switching the sodium bicarb to a continuous infusion. If we give a one-time dose, that's not going to last very long. So a continuous infusion would be helpful here for the tricyclic antidepressant as well as the aspirin. How would you dose your bicarb?
To a target urine pH goal of 7.5 to 8.5.
Excellent. So there's not necessarily a set dose of the sodium bicarb. We would start it at a reasonable rate and then titrate it to the urine pH. So oftentimes sodium bicarb is made with 150 milliequivalents per liter. You could start that at 100 milliliters per hour, you could start it at 50, you could start it at 150, anywhere in that range, and you would titrate it to your urine pH. Great. So we've got the bicarb, and you also said discontinuing the sorbitol because they're hypotensive, and I agree with that as well. There are a couple of reasons where we wouldn't necessarily want to use sorbitol in this patient. Good. How about group 5? Where are you? Anything else you guys would recommend?
We would give the patient cholestyramine as part of digoxin treatment also, in combination with the MDAC.
Okay. So you could consider cholestyramine as part of the digoxin treatment. That is an option. Is there anything else you would change with the digoxin treatment? So let's think specifically about the digibind. Is it indicated? And if it is, what should the dose be?
It's indicated because it's potassium, right? Is she asking anyone?
It is indicated because the serum potassium is above 5,
Okay.
and it's dosed based off of digoxin levels.
Excellent. How often do we dose it?
We don't know.
So it's only dosed once. It's given a second time if necessary, but not Q6.
Correct. So it is indicated in this case that the potassium is greater than 5, but it would be a one-time dose. We wouldn't repeat a digoxin level, and we wouldn't repeat the dose either. We would just give the one-time dose of digibind. All right, good. So we've addressed most of our orders here. Would anyone make any changes to the D50, 1 amp times 1? Or if you think you'd keep it the same, tell us that too.
Would you switch that to a continuous infusion also?
So it'd probably be a good idea. It's not necessarily a requirement, but given that they're very hypoglycemic to 35, you could give the 1 amp once and see how they respond. But glipizide has a relatively long half-life, so they're likely going to stay hypoglycemic for a little while. So you probably would want a continuous infusion. And you could also titrate that to your blood glucose levels and decrease the rate as their blood glucose improved and the glipizide effects wore off. All right, so we talked about the bicarb. So go lightly and calcium gluconate. See if we would make any changes with those or leave them the same. How about group 3? Where are you? Right there?
So we would keep the go lightly because it's good for eliminating drugs with longer half-lives, and we would also keep the calcium gluconate, but we would need to know the dose and frequency.
So the calcium gluconate is as an infusion, so a continuous infusion. Would you dose it that way?
No, just a bolus.
Okay, and what would you be using the calcium for?
That could be used for the calcium level as well as for the
the overdose on one of those drugs. What was it? I can't remember.
It's for the hyperkalemia.
So if we just look at our lab values here, the calcium might seem reasonable to give with someone with hyperkalemia. So I agree, I wouldn't do a continuous infusion here. I would just do a one-time dose of calcium gluconate. And when someone has hyperkalemia, it can be used to help stabilize the myocardium so that they don't have a serious arrhythmia related to the hyperkalemia. All right, so thank you for everybody's answers. Quick review of what I would do. I would want to check an aspirin and probably an acetaminophen level as well. Acetaminophen wasn't listed in our overdose, but it's always good to check an acetaminophen level when you have a suspected overdose. I'd want to check our aspirin level, which I think we mentioned. I've discontinued ascorbital because the patient is hypotensive and they're not going to need that with the multi-dose activated charcoal. The go lightly is debatable. You may continue it. You do have some of the drugs that have a longer half-life. You don't have any extended release products where the go lightly can really be helpful. The activated charcoal we talked about, I would change to the multi-dose activated charcoal with digoxin. We talked about changing to the bicarbonate to a continuous infusion. We would change our Digifab to a one-time dose, and we wouldn't recheck our digoxin levels. I don't think we mentioned magnesium, but I would replete the magnesium. The patient with hypomagnesemia could be at risk for torsades if they have QT prolongation. I would check an EKG, which we saw in the questions, and that the physician did that. We didn't see the results of it. I would do a one-time dose of calcium gluconate to help with our hyperkalemia. And you could consider other treatments for hypokalemia as well. So different things that can lower your potassium. So have y'all seen the acronym C big K drop? Can help you remember your treatment with hyperkalemia. So I'll give you an acronym real quick. I'm not a big fan of acronyms, but I know they help some people. So if you like it, you can use it, and if you don't, then that's okay. So the C is for calcium. So calcium gluconate to stabilize the myocardium. And then big, so the B is for bicarbonate or beta agonist. So both sodium bicarb and a beta agonist, so albuterol, shift potassium intracellularly. So that's the B. The I is for insulin, which shifts potassium intracellularly. The G is for glucose. It doesn't help with your potassium, but you give it with the insulin so they don't become hypoglycemic. The K is for K-oxalate, potassium binder. And then drop, the D, is for dialysis or diuretics, the furosemide. So not necessarily as relevant to this case, but you could use any of those treatments to help with hyperkalemia. Yeah.
No.
So the question was Digifab and Digibind are the same product. They essentially are the same. Yeah. Any questions about this case before we move on?
With the level of hyperkalemia that this person's at, would you give them dextrose with the calcium and then insulin and then the K-oxalate or some other cation exchange resin?
So that's a great question. So with this level of hyperkalemia, we want to see if they have EKG changes. So we ordered the EKG, we didn't see the results, but if they have changes, then we definitely want to treat this urgently. Even without EKG changes, the potassium is pretty high, so we're going to want to treat it. So we'll want to use something that will shift the potassium intracellularly and something else that will help to actually remove the potassium from their system. So the things that shift potassium intracellularly are the insulin, bicarb, and albuterol. So insulin we could do, but I'd be a little bit nervous about that, even if we're giving dextrose, because this patient's so hypoglycemic. The sodium bicarb, we're already giving through an infusion, so that would be helpful. And then the beta agonist albuterol you could consider. It's usually used more kind of adjunctively, but the bicarb can help for sure. In terms of giving something else to then eliminate the potassium from their body stores, I think K-oxalate would be good. Your other options to eliminate potassium completely are furosemide or dialysis. The patient's already potentially taken a week's worth of furosemide and maybe having some symptoms from that, so we probably wouldn't want to do that. So K-oxalate would be okay, and then dialysis I would only do if it's emergent, and that they are having EKG changes as a result. Does that answer the question? Okay. Any other questions about this case?
For the sodium bicarb under the aspirin treatment, it says to titrate to the urine pH of 7.5 to 8.5, and then for the TCAs, it's the serum pH of the 7.5 to 8. Is that just specific for like the TCA and the aspirin?
Yeah, it's specific for the drugs. In this case, the patient potentially had both overdoses, so you would just kind of have to consider which one you think is more concerning here. You should be able to check an aspirin level, so once that came back, we would know if they actually had a high aspirin level or not. I would probably, if you had both ingestions, go with the blood pH, but it would be reasonable to do either one. And if you had just one ingestion or the other, you would certainly use the urine for aspirin and the blood for TCAs. All right, so this one gets a little bit complicated when you have multiple potential ingestions, but this is pretty realistic. You can see things like this relatively often in the hospital. So let's go on to our next case. This one's not quite as complicated. So now we have a 26-year-old female who called EMS because she felt funny. The only significant information is that she recalled drinking Old Mountain Dew she found in her trunk of her car while she was changing a flat tire. She comes into the hospital, we get some labs. She's found to have a serum creatinine of 5.4, an anion gap of 31, and a pH of 7.03. So what is the suspected toxicity here, and what would you do about it? So we'll take a few minutes to talk in your groups about this one.
Yeah, metabolic acidosis.
Metabolic acidosis.
Probably uremia.
Maybe she drank like car fluid.
Ew. Yeah. Oh my god.
You know what's the difference between antifreeze and Mountain Dew?
Wait, but Old Mountain Dew, like,
No, did you know that
what kind of container?
that's why dogs drink it, if they get into it in the
What is the excess anion gap? We don't know.
Oh yeah.
Because we need a
How can it be Old Mountain Dew?
Well, she definitely eats bicarb. She's less than 7.2.
Like, who pours their Mountain Dew into something else instead of pours their antifreeze into something else? Instead of storing it, yeah.
What a dummy.
Plus that, like, the antidote for these things is ethanol.
Right.
Get them drunk.
Here's some 100 proof.
That's crazy. What? The people are dumb enough to be like, oh, look, some Old Mountain Dew in a not Mountain Dew bottle. Let me drink it.
Because she felt funny. What did you say? So what did you say? Stuff like this is all days that I want to work in like an emergency room, just so I can like see all the stupid shit that people do.
Just let them weed themselves out.
Oh my god.
That's how you fix it.
What?
Natural selection.
Yeah, Darwinism at its finest. Seems like a legit solution to me.
I suppose.
Who brought Krispy Kreme?
Katie did. World Cancer Day. Or week. I'm not sure. I think it's day.
I think yesterday was National Golden Retriever Day.
Interesting.
There's a national day for everything.
There's something in dialysis because there's it's like 0.4. It's like kind of high-ish.
Was it expired?
Well, not case 3 of 80 it's 10, but yeah, she don't have to hurry up.
All right, where's group 14? Where's 14? In the back. I can't see all back there, sorry. All right, group 14. What do y'all think's going on here?
Darwinism.
So we actually have no idea why this is actually happening.
Okay.
But we have an idea of what's going on. We can describe what's going on, but we have no idea why Mountain Dew would be causing this.
All right, describe what's going on to it for us.
Well, with some help from a buddy, we found out maybe an antifreeze.
Okay, so what would antifreeze do? Why do you think that?
It's creating a
Well, yeah,
gigantic
it's sweet,
antibody on
but more than that, it would do so with this sort of, very acidotic presentation with, a high anion gap. But we're also missing, some of the other stuff like, being drunk, which is, I suppose, is part of the reason why we didn't really get that. It does say she felt funny, but I guess we're looking for the keyword drunk. That's why I guess antifreeze passed over us as being the possible cause of this.
Okay, so maybe she accidentally drank antifreeze instead of Mountain Dew. That could be the possibility, and so she's having an acute alcohol intoxication. What type of alcohol is an antifreeze?
What?
Ethylene glycol?
Ethylene glycol, yes.
So she may have an acute alcohol intoxication. So what would we do about it? Group 8. Where's group 8? What should we do?
We said dialysis.
So you could possibly do dialysis to remove the alcohol. Any other options for treatment? How about group 25?
Yeah, I didn't know what that was. I didn't look over the whole PowerPoint.
You're in Savannah, right? 25?
Alcohol dehydrogenase.
What's that thing for alcohol withdrawal or addiction?
We're doing sodium bicarb.
So you could give bicarb to treat the acute acidemia and help to, as a supportive treatment. That's definitely something you could do. Are there any other options for actual removal of the alcohol?
You can give them ethanol or fomepizole.
Okay, so we have a couple different options of fomepizole or ethanol. So really we have 3 options for treatment here. We could dialyze the patient, we could give ethanol, or we could give fomepizole. So just a quick note on why we can give ethanol. I don't think I had all of these in your pre-lecture slides. So if we have methanol or ethylene glycol toxicity, in this case we think it was probably
It's a
ethylene glycol.
reaction.
They're both
If you drink
converted
alcohol with
to
metronidazole,
toxic
it's a
metabolites
reaction called.
by alcohol dehydrogenase, ADH.
Yes, that's right.
So fomepizole directly inhibits
How does that
alcohol
work?
dehydrogenase.
How does
So
that
it's
work?
an alcohol dehydrogenase inhibitor. So ethylene glycol and methanol are not converted to their toxic metabolites. Ethanol also binds to alcohol dehydrogenase, and it has a much greater affinity than ethylene glycol or methanol do. So that's why you could give just regular alcohol to the patient. It would bind more strongly to the alcohol dehydrogenase, and the ethylene glycol and the methanol would be eliminated as their parent compounds without being converted to the toxic metabolites. So you have the three different options here. Dialysis is an option. Can be an emergency care, so it may be something we need to do. But you do have to think that a lot of things go into dialysis, right? The patient has to get access for this to be dialyzed. So it can be a little bit of a process to do it emergently. Ethanol, there's some institutions won't do this because they don't like the idea from a kind of ethical standpoint of giving someone a substance that will intoxicate them, so giving someone alcohol. And fomepizole is great because it binds to the alcohol dehydrogenase, it works effectively, it's very, very expensive. So there are different considerations here. There have been a couple of observational studies looking at using ethanol versus fomepizole. They have similar outcomes. In this one study with ethylene glycol, mortality was higher when ethanol was used, so that may be an indication to use fomepizole. But overall, their evidence doesn't necessarily support one or the other. The cost for kind of your average patient over a 24-hour period for ethanol is about $30, and fomepizole is about $2,000. So that's definitely not going to be our only factor in making a decision of how to treat the patient. But we do like to keep that in mind. If you have two treatments that are equally effective, you might choose the one that's less expensive for the patient. In this case, I think either would be appropriate, and some institutions would prefer fomepizole over ethanol. How do you dose the fomepizole? Anyone remember?
A loading dose of 15 milligrams per kilogram, followed by doses of 10 milligrams per kilogram every 12 hours for 4 doses, and then 15 every 12 hours, 15 milligrams per kilogram until the concentration of ethylene glycol is less than 20 milligrams per deciliter.
Exactly. So you keep checking your concentration of ethylene glycol or of methanol. You can order those tests to get the serum concentration. Something kind of interesting about fomepizole is that you do have to increase the dose after 2 days because it will have increased metabolism. So it's 10 mg per kg for 4 doses or 2 days, and then you have to increase it. So that's kind of something unique about its dosing. All right. So the big thing with toxic alcohol ingestions is recognizing them. You actually do, this seems kind of crazy, but you see antifreeze ingestions, sometimes intentional and sometimes unintentional. So being able to recognize that, even if you don't get that report in the history, is really important and can help you to actually treat the patient. Symptomatic treatment is, of course, going to be helpful, but treating the actual cause will be even more helpful for these patients.
Dr. Smith?
Yes.
Yeah. So if we decided to go with ethanol for this patient, like how would you dose that? Would it just be like a beer or?
So different places have different protocols that are in use. My previous institution actually used vodka. So there was a kind of complicated titration about how much you would get, and we would check levels, and once your ethylene glycol levels were low, we would stop it. But you can actually administer alcohol through an NG tube, which is, like I said, brings up some other kind of issues to think about. All right, so let's go on to our next case. We now have a 57-year-old female who was admitted 2 days ago for osteomyelitis, requiring a left below-the-knee amputation. While she was on the medical floor, she's incorrectly administered a dose of IV methadone 20 milligrams that was written for the patient in the room next door. An hour later, the nurse finds her unresponsive. Her vital signs are listed here. So her blood pressure is 105/67, heart rate 61, her respiratory rate is low at 7, The rapid response team is called, and they place orders that you see here. So what would you do as the pharmacist? So let's just take maybe 3 or 4 minutes to talk about this one. It's a little bit more straightforward, I think.
Alcohol beer? And the pharmacist was like, yeah, it's not the withdrawal. And I was like, you approved an order for beer. And she acted like it was no big deal. No.
You should stop there.
Did you go again?
She goes every day, Austin.
No, she doesn't.
She does.
Yeah.
You did?
Candle.
You went again?
Yes. You should go like 3 times a week to maintain where you're at.
What? Every day. That's a lot. Probably every other day. Sometimes it's 3 days in a row, and I skip a day, and then
So on the PowerPoint slides and the pre-class slides, the naloxone treatment doses, the first dose should be 0.4 milligrams, not 0.04. So the first dose is 0.4.
it's still too high.
Where is that? What slide?
The means were they did.
Does it show you how charged it is?
You
have to like plug it in.
No, you don't have to, but it did die.
It takes like 5 seconds to charge, or 5 minutes. Like it charges really fast and it lasts for like a week. Can you check though?
Yeah, you can just like if I'm using it, you just like do this on your phone.
Oh, so it's like how I check if my AirPods are charged.
Yeah.
I'm still looking for one right on spending it first.
Do you have that? And are they like off-brand of them, or what are you trying to get them from?
No, I just want to have a pencil, but I've been keeping an eye on the open box ones at Best Buy. But the lowest I've gotten is like 85. And it's like, what the? That's still like paying with taxes.
I wonder if they have like student discounts on it. Do you have like a student account on Best Buy?
No.
Try to like, you can like Google like Best Buy student and in your email.
My dad buys a lot of stuff from Best Buy, so like sometimes they send me like rewards and coupons and stuff. And I was like, I could buy one that's open box and then like use this thing on top of that.
I got mine. I had my parents give me mine for Christmas. Not last year, but the year before.
But then I told him he was exempt because I was on the short bus.
And he gave you $40.
And so I don't want to be. Also, I told him to add it to my running list of things that I want.
Mine just always gets bigger.
My parents went to the Super Bowl thingy that was like happening in Atlanta all week. The whole experience thing, and they went without me. They like called me Saturday night on the MARTA, like on the way back home. I was like, guess what we did today? I was like, you guys know that I was here, not doing anything.
Yeah, my parents do that.
No response increase every 2 months.
You could have asked. You really work without me. My parents go on a cruise every year without me. Like, they just got off their cruise. So are you going to get your last one? Yeah, I went here yesterday, but I just got sidetracked. When do you go on Tuesday?
Oh my god, and then my cousin just commented.
about her saying swag. And my dad was like, yeah, I'm still stylish. What? I do not know you guys.
Just looked up below me and
They went to a Super Bowl party yesterday, and I was like, y'all are just living the life. My favorite thing about the halftime show was the special effects. It wasn't like, I wasn't a part of the SpongeBob and the, I wasn't a fan of the sicko mode. Yeah, the sicko mode was pretty good, but like,
I was like, Travis Scott seemed like he was like out of breath the entire time. I'm like, maybe you can stop jumping. Get your breath.
but Adam Levine was not impressed. I was like, and he kept being sick. He did. Also, his facial expressions were like,
He was like kind of like trying to pump the microphone. He was really high. If you continue, you're like falling lower and lower on my list.
I liked Bruno Mars. The Toppers, they were really good. They did it like a couple years ago.
I'm upset that Cardi B did it.
Do what?
That Cardi B did one. Way back.
Was she invited to do that?
She said no.
Alright, is everyone ready? Okay, so group 3. Where's group 3 again? What would you guys do here?
We would lower the naloxone dose to 0.4 milligrams and then consider increasing every 2 minutes as needed, and then both the go lightly and the activated charcoal.
Okay, does any group agree or disagree? I see some heads nodding, we agree. Alright, we would change our naloxone dose. So I want y'all get me confused. The initial dose is 0.04 milligrams. I apologize. So it comes in a 0.02. So you start very low and you can increase. There are some cases where some people suggest starting with a higher dose, but it's 0.04 and 0.5 and 2 as it is on your side. I'm sorry if I confused it more. But I agree with discontinuing the go lightly and discontinuing the activated charcoal. We don't necessarily need those in this situation. I heard a group in the back talking about how methadone can prolong the QT interval. So I would definitely recommend getting an ECG here to make sure that the QT interval is not prolonged. And then you might just want to review their profile to make sure they don't have any other opiates ordered, because we wouldn't want to give any others on top of this. All right, so our next case, we have a 42-year-old male who presents to the ED after being found unresponsive by his wife. EMS reports finding empty bottles of metoprolol tartrate, 50 milligrams, and amlodipine, 10 milligrams at the scene. But the quantities potentially ingested are unknown. So the vital signs when you get to the ED are listed here. What would you want to do? And think about any of your potential treatment options here. So we'll have a few different things to discuss with this one.
It is super inconvenient. What, charging the pin? Yeah. It takes like 5 minutes to charge. Like,
yeah, but in that 5 minutes, really I have almost broken her pin with my elbow. I almost snapped it.
Mine, like, I plugged it in 2 minutes ago and it's at 43%. And then it lasts for like a week. Yeah.
Wow.
Yes.
Ronnie is such an Instagram thought. He goes places so that he can take these pictures. That is the only reason. The only reason he goes these places. He looks good though. get student discounts on computers, can't you?
You only get $50. Like, it's cheaper to buy it at Best Buy. Alright, let's choose you. And we'll buy you. On the education page. Am I on it? Let me log in.
Can you get student discounts on iPads? Huh?
I don't remember.
Huh?
Here we go. It doesn't. What? Yeah.
Why
you
did we
do.
discontinue the Go Lightly and the charcoal for the opioid
She said it wasn't really needed.
No?
What is the iPad Pro usually cost? If you don't go to the education page.
I was saying it so that you would hear it, because I knew you'd know the answer.
So you still get $50. You get $50 off the iPads too. They go down $50.
So it'd be $7.50.
Yep. That's the Pro. Small? Yeah. This one's a Pro, but I got it for $500.
That's how much mine was.
I got it like 2 years ago.
Is this 11.9 inches?
This is
Yeah, that's the one I have.
So that is just as big as this.
I had
Or bigger, the
something
11.
where I just got $100. Yes.
It's like
Discount. I traded. Zach has this one.
good.
my dad like found he like someone came to our store and like dad gave him something that he like maybe like anything that I'm my manager at Best Buy.
Oh.
I used to just
Yeah.
to get my iPad.
How much of a discount do they get?
They were like running a promotion for when like it was like already $100 off and the promotion ended and he like still honored it and gave us like whatever their employee discount is like on top of the $100 off.
What is that?
My dad asked me that if I wanted
I need
to
to Accutane.
Yeah. I was like, yes,
Sure,
please.
it wasn't
I will
supposed to come in
take
like a week
that.
ago.
Yeah. Oh wait, there's a Apple shopping event. I don't know if the pen is on it. No. Not seeing a pen. Nope, no pen.
Alright, does anyone need more time? Ready to talk about this one? Alright, let's go ahead and get over it. So we have a beta blocker and a calcium channel blocker injection. So there are a number of different therapies that we can think about. So what was group 6? Group 6. What is something that you would consider for this patient?
Start with atropine first.
Okay, so you might start with atropine. What's that specifically going to treat?
For the bradycardia.
Mm-hmm. So atropine is good to help manage the bradycardia. How much atropine do you give? Do you remember?
Was it 0.5 milligrams?
Yeah, 0.5 milligrams. So this is the same atropine that you would give for symptomatic bradycardia that we learned in ACLS. So 0.5 milligrams of atropine, you can repeat that dose, and that'll help to initially manage the bradycardia. All right, group 9, where are you? Anything else you guys could consider?
If the patient didn't have any response to the atropine, we would start the HIET with 1 unit per kilogram plus dextrose 0.05 grams per kilogram, and then a maintenance dose of regular insulin of 0.5 units per kilogram per hour, titrated up to a max of 2 with dextrose 0.5 grams per kilogram per hour.
Great. So we we consider the high-dose insulin euglycemic therapy. So when you really think about this, this is a very high dose of insulin. If you think of somebody that's in the ICU, maybe in DKA, and they're on an insulin infusion to treat their hyperglycemia, the normal dose that you're going to see is they're maybe on somewhere between like 1 to 5 units per hour. Maybe you'll see up to 10 units per hour and think that they're really hyperglycemic, they're requiring a high dose if it's around 10 or so. We're thinking 1 unit per kilo. So if you have a 70 kilo patient, that's a pretty normal patient, that's 70 units per hour. So this is really high dose insulin. So if you were the pharmacist verifying orders and you saw someone with an order for 70 units per kilo of insulin, you definitely want to know what's going on. It might be reasonable because they might be treating a beta blocker or calcium channel blocker overdose. You'd also need to be extra sure that they have the dextrose order to go with it so they don't become severely hypoglycemic. Good. Group 18, I think you're in Augusta, right? Is there anything else you consider for this patient?
Because his heart rate is less than 50, we weren't sure about the glucagon and norepinephrine or cardiac pacing.
So these are all different options, right? And it can be a little bit challenging to figure out when to do each one. So transcutaneous pacing, that's recommended in our symptomatic bradycardia algorithms with ACLS, right? So if someone has bradycardia, they don't respond to atropine, then you might consider the transcutaneous pacing. And that would certainly be an option here if their blood pressure, or their heart rate, doesn't respond. So you also mentioned norepinephrine and glucagon, right? So the norepinephrine you could use to help support the patient's blood pressure. It might help some with their heart rate as well. And the glucagon you could also use. So determining when to use the glucagon versus the high-dose insulin therapy versus our other therapy, which is calcium, is really dependent on how the patient responds. So you typically start with one of them, see how the patient responds, and if it's not enough, then you add on another. You may, if the patient's both bradycardic and hypotensive, you would likely start with norepinephrine first, and then a lot of times I see that high-dose insulin therapy added second, followed by the calcium or the glucagon. Some different institutions have specific protocols for when you would add each one and what order you would try them in. In general, there's not a right or wrong answer for when you would add them, but think about the therapies that are kind of more readily available and what you could use the fastest. And norepinephrine is usually going to be kind of your go-to. We use that for most patients that are hypotensive, right, that need a vasopressor. So that will treat your hypotension, then we can think about our other options. Any other therapies that you could use in refractory cases? So we mentioned glucagon, insulin, norepinephrine, calcium, atropine. Is there anything else you could consider?
Lipid rescue?
Lipid rescue. So there are a few things that you can use lipid rescue for, and beta blocker and calcium channel blocker overdoses are one example. So I'm going to talk a little bit more about that in a second, but in general, my plan for this patient would be to consider options for supportive care. We don't really know, I don't think we knew about the timing of this ingestion, so you may not want to do any of our measures to remove the drug, but you might consider those if you knew the time of ingestion. For supportive care, we think about fluids and vasopressors, atropine and transcutaneous pacing we mentioned for the bradycardia. And then for our specific therapies, we could do the calcium, glucagon, high-dose insulin euglycemic therapy, or a lipid emulsion. Things to mention with our calcium and our glucagon is that these are both going to act quickly, so you would use a bolus followed by a continuous infusion. So I wanted to just bring up something for a practical consideration with our lipid emulsion. So if we think about our dosing for a lipid emulsion, it's usually a 1.5 mils per kilo bolus followed by a continuous infusion that's continue just as long as they need it for their symptoms. So we had our patient here. He was a 32-year-old, 6'2", 122 kilo patient. So his bolus dose would be about 120 milliliters of the 20% lipid emulsion, which is our standard lipid emulsion that you push over a couple of minutes. So no problems there. Our infusion, when we calculate that out, our 15 mils per kilo per hour, comes to about 1,200 mils per hour. I point this out because from a practical standpoint, this is difficult to do. So our infusion pumps in the hospital will typically infuse at a maximum rate of 999 milliliters per hour. So basically a liter per hour. So this isn't rare, but when it comes up, the pharmacist will typically get a lot of questions because how do you infuse lipid at 1200 mils per hour? So typically what you do in this type of situation is actually have two different infusion pumps going, and you'll have each infusion set at 600 mils per hour, or whatever combination you want to get to your total rate of 1200 mils per hour. So this isn't something that y'all need to memorize for exam purposes or anything like that. I just wanted to bring it up as a practical consideration of how we would actually do this in real life. Questions about that? All right. One other just practical thing to think about, again, we don't base our treatment decisions off of cost alone, but I think as a pharmacist, it's good to have at least a relative understanding of what drugs cost, because you'll get questions about these in the community and in the hospital as well. These prices up here are the average wholesale prices. These are a couple of years old, so they may have changed some, but just to look at the relative cost, if we're thinking about the cumulative price for a normal about 70 kilo patient, things like calcium and epinephrine or norepinephrine are relatively inexpensive. Glucagon is extremely expensive. So I actually had a patient that required glucagon for a really terrible overdose during my residency, and we ended up having to get glucagon supplies from like 6 or 7 different hospitals across the state because they were going through so much glucagon. So they require a lot of it, that bolus and then a continuous infusion, pretty high dose, and it's very expensive, but it's effective. So a lot of times because of this, we might try our other effective therapies first and use the glucagon a little bit later down our list. All right, questions about this case? Okay, so let's do this next one. We have a John Doe who was brought into the hospital by EMS after being found in the bushes outside of Burger King. He's unable to provide any information about his condition or his medical history. We have his vital signs that are listed here, and on physical exam, we find an unmarked pill bottle in his pocket. So, what would you do?
is a Fiesta. I think it's the first one.
So Daniel.
You're so stupid.
Where'd she go?
What deal?
What deal, John?
I was gonna buy her iPad and she could buy that, but I'm not looking at this.
What are you gonna get?
Huh?
What are you gonna do? You gonna get an iPad instead? Is it for me? For you?
No, it's for me.
Are you gonna get a pen? No? Why not?
I'm not willing to look at that much money right now.
Tell Blake to get it for you.
I want a pen for my birthday.
Yeah, tell him. When's your birthday?
Brandon said I can get me a pen.
Sure.
It's just that you are so tan.
Yeah.
Hey, it was last night.
Is it fake? Have you been putting the lotion on your hand?
No, I have not.
Are you sure?
Oh. Because it was for, no, I really have gotten this dark, but the two shades darker today versus Friday.
You're a fraud.
Or like a couple of the strongest players bet against themselves, and then they threw the games, they win the money.
Okay, just today.
It's a good one though, because like your knuckles aren't all in your palms, you know.
Did you get that at
I had a free one. And they were like, it expires tomorrow. And I was like, free?
Yeah, I wonder how long they last. I wish like if I could.
I was like, why the fuck
Some of the
not?
like tanning ones are actually really good, like the self tanners. But it's just me getting to my back. Like I'm scared. Like it's gonna be so patchy on my back. So I'm like,
Get someone else to do it for
I
you.
know.
Taylor showed me this last night, and he was like, you're darker than her shadow. And I was like, no, I am not.
But you
I've never gotten a spray
definitely have the
tan.
hands of like a mixed girl. Awesome. Let me see your hand.
Let's compare our color.
Yep, skin is darker.
Well, there's different undertones, but
He's telling
almost the
us
same darkness.
I think she needs to stop too.
Just don't like.
She's
Savage.
Let's put her in a hot tub and see what happens. Can we make tea?
All right, do you guys have an idea of what you do for this patient initially?
Yes, whatever. Like Friday.
How about 23 and all?
Today is
What would your initial plans be?
We could do a urine drug screen, also check for acetaminophen, aspirin, alcohols, look at his serum creatinine and ECG, and maybe also give naloxone.
Yeah, I think that's excellent. So we go ahead and get our labs. We probably want to get a BMP. We get a urine drug screen, add on aspirin, acetaminophen. We can check our alcohols. We want to get an EKG to see if he has any arrhythmia going on, and get all the information that we can. And I think when someone's found down like this, you think there's an intoxication, you don't know what, it's reasonable to give a dose of naloxone for sure and see if they respond or not. Does anyone else have anything they'd add to that initial plan? Yeah.
Says he has a pill bottle. Maybe there's some left in there. We can maybe identify some pills.
I think that's an excellent idea. So you get all of your information, you stabilize the patient, you have the pill bottle so you can figure out what it is. So here is your pill. So let's see what we would do now.
I'm just guessing. Opioid.
100. That's it.
You sent it.
17? Oh, you're in Augusta, aren't you? Sorry. Have you been able to identify this pill?
Yes.
Yes.
What is it?
ER 100 milligrams, which is the Pentanol.
Okay, good. So what would you do? Would this change your, or give you any other ideas for your plan?
No, we'd still do naloxone.
Okay, I agree. So we have given naloxone. The nurse has now given 4 doses with the dose escalation, and he quickly becomes more somnolent. So what would you guys want to do now? You can talk with your group for a minute here.
Needs a naloxone drip because
Patient would need a naloxone drip because it's an extended release.
Excellent. So we want to do an infusion. So can anyone tell us how you determine what rate to start your infusion at?
2/3 the effective bolus dose per hour.
Exactly. So if the patient got 4 doses in that first hour, then we would calculate 2/3 of that cumulative dose. So we did our dose titration and started at 0.04 for our first dose, and then increased. What would our total bolus for the first hour be?
she asking us. Stop.
How about group 15? You're here in Athens, right? Where's 15? How would we figure out what our total dose for the first hour was?
Of 4.3 milligrams per every hour.
Okay, so how did you get that? You did 0.04 plus?
Plus 0.5, plus 2, plus 4.
Okay. Oh, so you're telling me your actual rate, right? The 2/3 of that?
Yes.
Okay, perfect. So we would get our total dose for that hour, and then 2/3 of that would give us about 4.4 milligrams per hour. So this would be where we start our infusion, and then we can adjust it based on the patient's response. But we'd start at 4.4 milligrams per hour. So let me just, once and for all, clear up the confusion that I started with your naloxone dosing. So, and you might have some confusion when you look at other drug resources as well. So 0.04 is the traditional starting dose. There are some recommendations now, particularly in the community setting, to go ahead and start at a higher dose of maybe 0.4 milligrams because of all of the opioid overdoses and deaths that we're seeing. It's better to give a little bit higher dose in the community than to start at a lower dose. The dose escalation, the dose titration is not really recommended in a community setting because that's just something that you would want a healthcare provider to be involved in, actually titrating and escalating your doses. So the traditional starting dose in the healthcare setting is 0.04 milligrams with the dose escalation that's listed in the slides. You may see a healthcare provider or a community member start with a higher dose, but the recommendation to start with is the 0.04. Are there questions about that? Okay. We won't make anything too confusing for you about that for exam purposes, but it is 0.04 for your first dose and then go from there. All right. So let's do this next case. Case 8 is essentially almost identical to other cases. We might just do case 7 as a class, and then if you have questions about case 8 later, you can come back and ask me those. So case 7 is a 15-year-old male who's brought to the ED by his mother after admitting to taking a whole bottle of vitamins after his girlfriend broke up with him. His patient reports some nausea, but he's otherwise stable. So what would we want to do? So take just a couple minutes and your initial plan.
That's my pill of choice. The overdose on. To overdose on, yeah. Vitamins.
Gummies, right?
Yeah.
Contain iron.
You're good, actually. Surprisingly.
All right, so let's go through what we would do for this patient. So let's go to group 26. You're in Savannah. What would you all do for this patient?
We said we would find out if the multivitamins had iron in it, and if they did, we would get antidote.
Great. So the main vitamin that we're concerned about is iron, and we do have an antidote for that. In this case, we find out, the mom finds the bottle of vitamins, and we find out that it was 42 tablets of vitamin C. So does that change or affect anyone's recommendations?
Go home. People
You
have
still have money on an account that you
He's always
you
wanted.
can't use it after graduation.
So I hear some discussion here in Athens that vitamin C is not fat soluble. It's a water soluble vitamin, and that's correct. So we have more concern of overdose with our fat soluble vitamins, so A, D, E, and K. Vitamin C is water soluble, so it's less concerning. Depending on the time of ingestion, we might consider a method of drug elimination, but in this case, we're probably going to monitor the patient, give supportive care if needed, and it's likely not to be as significant. But when someone comes in, whenever we're not sure about the overdose, you definitely want to do all of your initial workups. So get your drug levels, get a set of labs, your electrolytes, CBC, urine drug screen, add on aspirin, acetaminophen, maybe the alcohols, depending on their presentation, and get as much information as you can. This also brings up the point that with ingestions, the actual disposition of a patient when they come in with an ingestion of some sort, when they come to the emergency department, what happens to that patient, depending on how they present and what the source of the ingestion was, could be anything from watch them for a couple hours in the ED to send them home and tell them to call if anything happens, or they could go straight to the ICU. It just really depends. For some patients that present and they appear okay initially, depending on what the type of injection was, there might be a large risk of decompensation, so maybe those patients will be admitted. So it's really all across the spectrum what patients are going to look like. This patient you're probably going to observe, provide supportive care, and potentially give activated charcoal. All right, so the last case we're not going to go through together because of the risk of time, but it has a similar injection that we've already talked about in case 1. So this was an unresponsive female that was found in bed by her son. She had bright red blood per rectum. And her hemoglobin was 3.6, so that's very, very low, right? She's never been to a doctor, but her son says she uses Goodies powder a lot. She's hypotensive, her heart rate's okay, has a little bit of a fever. So in this case, we would work up the patient like we do for any types of ingestion. So we would get all of our labs. We would definitely want to get an aspirin level in this case, right? Because we're concerned about aspirin and the Goodies powder. And then we could consider some specific treatment. So we could consider a bicarb infusion or dialysis if we needed to. All right. So are there any questions about anything from these cases or from the pre-class material? Any questions from the extended campuses? All right. If you do have any questions later, please feel free to email me and be happy to answer those. Have a great day.